Hello and welcome to SimCast, the higher education simulation podcast. My name's Tony Jeremy. I'm the academic lead for simulation-based education at UEA Norwich.
Hello everyone and welcome back to SimCast. My name's Lawrence Hill and I chair the simulation group in the School of Health Sciences at UEA Norwich.
And SimCast this week comes live from the Anaesthesia Associates annual conference, which is being held at the Assembly House in Norwich, so local conference.
Local conference, yeah, really nice not to have to get in the car and travel miles to be here today.
And really nice for you to be able to make one of these live conferences for once.
Yeah, it's probably got something to do with the geography, to be fair. So what are we doing here today then?
So because this annual conference is local and it goes all over the country, we were asked by people, so Anaesthesia Associates local organised sort of the events.
Yeah,
and I got invited to do one of the workshop presentations yesterday. We're at day 2, and we got asked to bring the podcast here to talk a little bit about the conference, a little bit about the profession, and we'll talk a little bit about that in a minute. And we've also got some keynote speakers today who, some are sim related, some are a little bit more about the profession, and we're just going to explore.
Yeah, absolutely. And I, as a complete outsider, obviously, I think people may know I'm a paramedic by professional background. Yeah. So I will be able to ask some naive questions about some of these things. But really, for me, it's about understanding how and why this might relate to simulation-based education and how, I suppose, anyone who normally listens to this podcast could sort of see opportunities in seemingly, you know, not unrelated, but kind of tangentially related topics and draw stuff out about sim. That's
a really, really valid point. So I think for our viewers and listeners, firstly, my background's operating department practice. Anaesthesia Associates, they are non-medically trained staff who will end up delivering anaesthetics when they're qualified. So it's an advanced practice role, similar to an advanced care practitioner or a physician's associate, but it specialises in anaesthesia. So the people that generally speaking go into these roles are people like ODPs, people like anaesthetically trained nurses. You can go in with a previous science degree and no healthcare experience.
Okay.
I met someone yesterday who did that and they said it was quite an eye-opener then going into healthcare. But this is I think it's a 2-year degree, master's degree at level 7. And because it's quite niche, there's only 3 providers in the country that currently provide that program. But there are anaesthesia associates all over the country. And actually, as a profession, it's relatively new. It's been going for about 20 years now.
See, I can identify with that. A paramedic is a relatively new profession. I suppose ODP is a relatively new profession.
We both, at the beginning of our careers, went through the professions going into registration with the HCPC. So we know what that is like. And again, I'm slightly naive on it, but my understanding is that anaesthesia associates, a bit like PAs, are currently not registered, and there's some politics and complications around that.
Yeah, I imagine some very real-world challenges and I dare say concerns as well from various quarters, and I suppose having conferences that demonstrate the kind of the academic rigor and the professionalisation are a really important part of establishing yourself as a professional group with an identity. So
some of the keynote speakers today on day 2 are people from Royal College of Anaesthetists, the General Medical Council, and other areas of the NHS, and they will be looking at updates and they'll be discussing all of these things.
And we're going to be bringing them in and getting some tidbits and kind of golden nuggets off them in terms of what they're talking about and why that matters and how that relates to simulation.
We've also got another keynote speaker who is talking today about human factors, and that's an area that I'm interested in as well. And I actually ran a workshop yesterday on day 1. So day 1 was more workshop based. And I ran my workshop on human factors analysis. So looking at a well-documented case in anaesthesia, which I knew that all of the AAs would know. The
Elaine Bromley case?
The Elaine Bromley case. And then we kind of picked it apart with the shell model, which we've now redesigned into our site model.
Yeah.
I thought, use the original
shell.
I use the original shell model, something that they could understand with. Yeah. So we'll put a link to the model, the episode where we talked about that.
Yeah, cool.
The other workshops that were happening on day 1 were a bit sexier than mine, to be honest with you. So they attracted a little bit more attention.
Okay.
I think if you know and understand about human factors and you're into it, it was quite an engaging workshop. And one thing I would say is all the delegates that did come, they were fantastic, and they really were able to use the model, pick out some of the areas and the failures within the case, and apply it appropriately. But the other workshops, they were doing kind of ultrasound guided approaches to traumatic patients and trauma, spinals using ultrasound, which is great, really interesting, and difficult airways. So again, they were much sexier workshops.
Yeah, fair enough. I can see that. But yeah, that's always the way at a conference, isn't it? There's always often, I should not always, but often competing kind of talks, and yeah, that's always going to be the way.
So what we'll do now...
So what did the one person that came to your talk think of it?
The one person went, I'm in the wrong room. And then left and went did some difficult airway. No, that was really good. Really good, engaging conversation.
Good.
People from around the country, all sharing kind of common issues, ideas and problems and potential solutions as well, because again I wanted to make it meaningful.
Cool.
But I was able to get some footage of some of the keynote speakers. Now, because we were running parallel sessions, I wasn't really able to go in and see those sessions, which was really frustrating actually, because they sound really interesting. But I grabbed the keynote speakers at the end of the day and had a quick chat to them about what they were doing in their workshops. So we'll go and have a look at that now.
Perfect. Thanks very much.
Okay, I'm with Siew-Ling Harrison now, who's a consultant anaesthetist at the Norwich University Hospital. Siew-Ling, thank you for taking a few moments to come and talk to us about the workshop that you've been running today. So tell us a little bit about what you've been doing.
Okay, so our one was an airway workshop, basically. Okay. And we divided it up into lots of different skills. So the first thing they did when they arrived is we had almost like a case-based discussion around a potential difficult airway. And I think that's really important for AAs who might go and review sometimes ASA1, ASA2 patients, and actually they have an unexpected surprise when they go and approach the patient. So it's being able to identify those who potentially might have a difficult airway. So we did a kind of case-based discussion with a lot of interaction for them to make sure they ask the most relevant questions and know when to escalate. Okay.
So a little bit practical and also a little bit of kind of communication, technical, non-technical skills, that kind of thing.
Absolutely. Okay. So we started with that in terms of discussion, and then we divided up into 3 groups, and we did EFONA, so the emergency front of neck, which we all should be familiar with.
Yeah, but it doesn't happen very often in practice, so that's why it's even more important to train.
Absolutely, and everyone should be doing that on a really regular basis. Yeah. So that was a practical stage. And then we looked at different types of video laryngoscope that they might be using in their trusts, and how to use the different techniques associated with a hyperangulated blade versus a regular Mac blade, and all of the adjuncts that might be needed with a hyperangulated blade, like a bougie and a stellette. Yeah. And then we did a station using ambuscopes as well. So it may be that they might not be the first line person to use an ambuscope, but they should be familiar with the technique so they can assist with that as well. And so they had a bit of time utilising their skills with ambuscopes. Great.
45-minute workshop, loads to get through.
Yes.
And I've been doing a parallel workshop. I'm pretty jealous actually, because I would have loved to have come and seen it. But thanks very much, Siew-Ling, for telling us a little bit about your workshop.
Oh, that's fine.
Okay, so I'm now here with Joe Walker. Joe is a consultant anaesthetist at the Norwich University Hospital. Joe, thank you for taking a couple of minutes to come and speak to us today. What's your workshop been about today, and how is it important for AAs, Anaesthesia Associates?
So we've been looking at back ultrasonography over the course of the day in the workshops, and we've been looking at basically the basic views that you get when you use ultrasonography pre-procedure before spinal anaesthetic, so that your needling can be reduced, your time to put in the spinal anaesthetic can ideally be reduced, and it's an extra skill in your repertoire really, particularly when you have patients with challenging backs. Yeah. So we're talking about patients with obesity or scoliosis, where using landmark techniques can be quite challenging. Yeah, so you can use the ultrasound to help guide you.
So I left practice in 2011, and ultrasound was a thing, but ultrasound for spinal and regional anaesthesia wasn't as prevalent. How often does this happen now?
So I'm an obstetric anaesthetist, so we use it fairly routinely. I would use the ultrasound probably, 2 or 3 times in a shift. And I think it's increasing use because of the demographic of patients. We have rising obesity levels in our patients, and so using bony landmarks can be sometimes quite challenging because you're not feeling those bony landmarks, and so using the ultrasound can give you an extra window into where you need to go with your epidural or your spinal.
Okay, so certainly a skill that AAs need to be aware of and maybe even use in some situations in patients.
Well, I think AAs are quite commonly do a lot of orthopedics.
Okay.
And so it's a skill that it's free. Ultrasound machines are in practically every anaesthetic department. We're using them for lots of other procedures. We're pretty used to using the ultrasound, and it's painless and it can be quite quick. So I was saying in the workshop today, why wouldn't you use it?
Yeah.
If you've sat your patient for their spinal anaesthetic, you just can pop the probe on.
Have a quick look.
And you can have a quick look. You can find the midline with the image and you can mark the midline, and that might be where you want to stop. Or you can turn the probe parasagittally and you can mark the height as well, so you can know exactly that you're in L3, L4 or L4, L5 level as well. So that's something that as anaesthetists we think we're quite good at, landmark techniques, but actually lots of research study would show that we're probably only right about half or less of the time.
Okay, interesting, really interesting stuff. Thank you, Jo. Thanks very much for coming to talk to us.
Pleasure.
And fascinating to hear about what we can do now with ultrasound.
Great. Thank you very much.
So I'm with Dr. Roger Garforth, now consultant anaesthetist at Norfolk and Norwich University Hospital.
Hi.
You've been running a parallel workshop.
Yeah.
Day one. We're at the end of day one now.
It's been fantastic.
That's been
We've
good,
had 4 groups. We've had about 11, 12 delegates
you
in
had
each
a
one.
popular workstation, haven't you?
Oh, yeah.
In first-line trauma, regional anaesthesia.
Yeah, so we've been doing those Plan A blocks that that are really useful in trauma. They're what we call a high-impact block. So they're easy to do. They're easy to teach.
So for people who don't know, this is ultrasound-guided nerve block.
Yeah.
So you're isolating one part of the body or limb.
Yeah, so you can use it mainly for analgesia, so pain relief for somebody who's got a broken bone or broken ribs, for example, something like that. A lot of the time we're using it in combination with a spinal or a general anaesthetic, but for some procedures, say wrist fractures, that type of thing, or tendon injuries, we can do them under the block alone, so the patient can stay awake. And it's a win-win situation as far as I can see.
Okay.
Patients are often a bit nervous, but part of the training is how to, counsel somebody about it, the pros and the cons. And the vast majority of patients who do go through these procedures say, that was brilliant. I'd love to have that again.
Okay. So there's some technical skills there, but like you say, there's also some non-technical skills.
There are non-technical skills as well. Yeah.
So you've been going through that today with the AAs?
We've been going through that today. We're doing the technical side of things today.
Okay.
So we had 3 workstations. We had one about upper limb blocks. So that was Matt talking about axillary blocks. That's a great block if you've got a tendon injury or a wrist fracture, as I said.
Okay.
Kate Tabrett, who's one of our ST5s, who's very enthusiastic about teaching and very enthusiastic about involving our anaesthesia associates and student anaesthesia associates, as well as the ODPs and the student ODPs, working as part of the team. She's been teaching about femoral nerve blocks.
Okay.
So we use those for hip fracture surgery, typically in elderly population who may have just had a simple fall at home from a standing height. It's incredibly painful having a hip fracture, and these nerve blocks are very effective. And I've been talking about what we call an ESP block. That's an injection in your back in the midline. It's not an epidural. It's a bit like a paravertebral, but it's incredibly effective for rib pain. So that's what we've been talking about today. So the management of rib fractures.
And these blocks now done under ultrasound. When I was in practice 11 years ago, they were starting to come in, but they certainly weren't anywhere near as popular as they are now.
Yeah. So ultrasound, especially the new ultrasound machines, really good definition of the tissues, really good images. With training courses like this, workshops, and lots of information you can find online, lots of journal articles, lots of books written about it, but there's nothing quite like something hands-on.
Having a go yourself.
And yeah,
so you've had 4 ADP apprenticeship students who have been your models for the day.
They've been the models, yeah. So they've all been great. I involved them in the teaching as well.
Excellent.
And they've rotated round. They've seen it, some of the other blocks as well, and they're really involved in it as well. Yeah,
great stuff.
And the enthusiasm just flows. Every single delegate who's come through has come in smiling and left smiling as well, and that's pretty good out of the whole day. That's been a great feeling.
Good.
Yeah. So I'm very keen that Anaesthesia Associates learn these skills. Mm-hmm. It is in the consultation, the draft consultation, about under supervision in selected patients having femoral nerve blocks or fascia iliaca blocks. So that's one part of it. And they're a very easy, very effective block to do. So they're high impact blocks, but we have other ones as well. We call them the Plan A blocks.
Okay.
And I'm a firm believer, and in that anybody can learn how to do these blocks. I've successfully taught them for many years on many courses. I've taught lots of anaesthetic residents, we're calling them now. I've taught consultant colleagues, and I've taught our anaesthesia associates as well to do some of these blocks.
Fantastic.
Okay? And I'm very keen that with the extended scope of practice that will hopefully come out of this consultation period, that over a period of time that we might be able to extend the range of blocks from just fascia iliaca blocks to other high impact blocks. Yeah. So something like an auxiliary block, forearm blocks, and popliteal blocks. I think that would be a very good start.
Yeah. So it's worth. I think it's just worth bearing in mind for our viewers who are not aware that the role of the AA is continuously sort of evolving and changing as the profession.
As the profession changes develops, and as the wider health economy changes as well. Yeah, and obviously people will learn these under supervision. They will practice them under supervision. But I can envisage a time when people have been supervised and have done, say, 50 blocks, that they could be signed off as competent.
We hope to see those kind of things in the future.
Absolutely.
Roger, thank you very much for coming to speak to us.
Okay.
So that was day one workshops.
Yeah.
I actually there was an extra workshop.
I feel a bit of a fraud being here at the beginning of this episode because I wasn't here on day one.
I know. So I didn't manage to get hold of there's one person, hang on, I'm just going to have a look at the programme, on day one. So who was it? Depth of Anaesthesia, Rhiannon Jones. Couldn't grab hold of her to talk about her workshop. And I also was reliably informed that she didn't want to do it.
Oh, fair enough.
So,
that's all right. Well, she's made it onto the podcast anyway by proxy.
By proxy,
yeah.
But there was there was 5 workshops, and the delegates had to pick the top 4.
Right.
Which was why mine was a modest attendance.
Yeah, good.
But,
I'm sure that person really enjoyed it.
I won't take it personally.
No, of course not. So
we're here on day 2.
So day 2. So I'm actually here today on day 2, which is great, and there's a really interesting looking schedule ahead for the day. So we're going to try and catch up with as many of the speakers as we can.
Yeah. So let's have a quick look and see what's on the schedule. So we've got the first keynote is AI and anaesthesia, wider healthcare and potential implications. That sounds really interesting, doesn't it?
It does indeed.
Dr. John Paul Jeans, I don't know how to pronounce that. We'll find out when we speak to him. We will,
yeah. So that'd be good. And then
we've talked
civility.
about AI ourselves, haven't we, in simulation as well. So we'll put a link to that in our episode where we used AI to generate some simulation scenarios. Probably different in anaesthesia, but we'll see.
Be interesting to know, wouldn't it? And that's going to be a feature, isn't it? I think of contemporary healthcare scholarship is going to be AI's role. So that's good. And then we're going straight from artificial intelligence to human factors and civility, which is a nice little flip flop there because one's obviously intensely about technology, and the other one then really very much about people and the interactions between them. So that is going to be interesting. So Mr. Nigel D. Roberts talking about human factors and civility in operating theatres.
Yeah, really interesting. And that's where my passion and interest for human factors came from, that background in operating theatres, looking at that really complex system of a patient having surgery, lots of individuals involved, and then understanding, how error can occur. I've had a quick sneak peek at Nigel's presentation. He's got some very interesting things there, examples of how these kind of errors occur in operating theatres. So it'd be fascinating to speak to him. And he's interested in sim as well. So we'll get his insights on that as well.
Perfect. And then we've gone from the kind of tech and humans into what feels like quite a kind of regulatory, political kind of section.
Yeah,
so we've got
the next three presentations are from the General Medical Council, Royal College of Anaesthetists and NHS England in terms of their updates, presumably around the profession, the Anaesthesia Associates profession. So, and the Anaesthesia Associates also had their, what do they call it? Their annual meeting.
Oh, the AGM?
The AGM meeting yesterday, which I didn't obviously take part in. But a very important time, I think, in the profession's
Yeah, it's a time of becoming a profession, isn't it? I suppose, and that may be what we'll hear a little bit more about that today. But that journey of becoming, going from perhaps a necessary and very effective role to being kind of ordained as a profession. That's an uncomfortable and probably long journey that lay ahead of.
But it also links into things like
associates.
Future workforce planning for the NHS and how that all plays a part with advanced practitioner roles as well. So probably some really interesting stuff, and be interesting to see if there's any contrast between the different bodies and their approach to it.
Indeed. And then the kind of the final kind of main section, I suppose, of the day is going to see the creation of an ambulatory procedures unit at the Norfolk and Norwich Hospital, which is the sort of largest main District General Hospital
in Norfolk and Suffolk.
Suffolk, there are other hospitals are available.
Yeah, but just for reference, 1,000-bed hospital, which was built back in the early 2000s, PFI building, and already it's stretched to capacity to the extent that actually big new kind of extra buildings and centres are being built from it as well. So again, looking at understanding that capacity, and obviously with ambulatory, walking in and out same day sort of surgery, a huge potential boiling pot for things like same day procedures.
Interestingly, then we're going back to civility, empathy and emotional awareness. I wonder if there's, I wonder why that is. Is civility something, I think it's something that all healthcare professionals should be talking about, but the fact we've got two talks that reference civility in the same programme, I think that is there something in that? Potentially,
and again, potentially it might be some civility and empathy about the profession as well. So maybe there's a metaphor there for where the profession is within its journey itself, and how that fits into the wider.
What is the meta narrative around civility in relation to emerging healthcare professions? Maybe we should ask that question.
Yeah, and I think what we'll try and do as well, we'll grab the chairs for some of these sessions. So these are Anaesthesia Associates that are from the local region, the Norfolk and Norwich University Hospital. So we'll try and grab Paul Cutts, who's the chair this morning, and we'll get an insight to what it's like to be an Anaesthesia Associate. And
can I just say that Cutts is an excellent name for anyone involved in anaesthesia and surgery.
I used to work with a Mr. and a Dr. Payne as well, which is always a great one. Jeremy's pretty rubbish for a healthcare surname, isn't it? Because it's got those connotations of sort of infection and sexist.
Yeah, nice. Yeah. Well, and then the final is closing with a keynote from Simon Harmer,
inspirational speaker,
TEDx speaker, no less. So we're looking forward to that one, and getting him on the pod at the end, and then closing by Sarah Massey, who's bringing the conference to a close. So yeah, looking forward to it. Should be fun, and hopefully some interesting nuggets for you listening at home.
Okay, so first speaker of the day was Dr. John Paul Jeans.
Yeah.
Now, we're doing a terrible job because we actually don't have John here talking on the podcast because he was so busy and he had a train to catch.
Yeah, he's flying on a train back to London.
So we literally collared him for 2 minutes.
Yeah.
and had a little bit of a flavour and an insight into what
absolutely.
he was talking about.
So Dr. John's talk today was about the emergence of AI within healthcare and the opportunities it presents within anaesthetics. And the very brief chat we had with him, he was like, it's going to change everything.
Yeah.
It's going to change
everything. So exciting, doesn't it? And I think capturing that in a couple of minutes on a podcast probably is doing it a disservice.
Yeah, 100%.
So what we're going to do is we're going to get John back on the podcast in a future episode, and we're going to explore the impact of AI in healthcare and medical education.
In medical education, in simulation-based education, and possibly with a kind of anaesthetic flavour, but that will have transference to any conceivable healthcare domain.
It's going to be a mind-blown moment, I think.
So looking forward to that one, and I hope we can get a few more of the actual speakers to represent themselves later on today. Yeah,
but again, if you need your AI fix, watch our previous episode on AI and how we used it to develop simulation scenarios.
And I'm prepared for us to look really amateurish with that when we get Dr. John on to talk.
Our kind of archaic caveman approach to using AI in simulation.
No, we're ready to be schooled, and we look forward to that in a future episode.
Yeah, great stuff. Okay, we're now joined by Sarah Massey. Sarah, thank you for joining us on the podcast. So can you give us a brief introduction, who you are, what you do, and why we're here today?
Yep, thanks for the invitation. So my name's Sarah Massey. I'm an anaesthesia associate. I currently work in London. And I'm also president of the Association of Anaesthesia Associates, and you've joined us here at our conference, our annual conference today. So really glad that you could be here and interrogate me.
Let the interrogation begin.
So, Anaesthesia Associate, what did you do before?
I was a graduate, so I was a biology graduate.
Okay.
I actually started in this profession back in 2007,
okay.
Straight after my biology degree. And I trained and worked in Birmingham for a while, and then I moved down to London as an anaesthesia associate. So my background is obviously a graduate background, but many anaesthesia associates come from healthcare professional backgrounds, such as the ODP workforce or the...
So we fumbled through a little bit of the history with our own ignorance at the start of the podcast. So it's about 20 years old, the profession?
Yeah. So the initial pilots was in 2004.
Okay.
So pretty much 20 years since the original pilot program started, which took a small group of healthcare professionals and then went and developed a curriculum and the training associated with it. And we're here now today,
so forgive me, so I'm a paramedic by background. I don't really have much, and I dare say people listening to the podcast come from a wide variety of different disciplines. What is an anaesthesia associate?
So anaesthesia associate. We're often referred to as AAs, obviously, the shortened version. And an anaesthesia associate is a professional who delivers anaesthesia, obviously within a theatre environment, so operating theatre environment. And we are a supervised professional. Most commonly, we work with our supervisors who are consultant anaesthetists or other autonomously practicing anaesthetists. And they will supervise our practice, but effectively we are delivering anaesthesia. And the very much ethos of the AA is strengthening the workforce, increasing the team, and adding flexibility to the anaesthesia team. So building a multi-professional anaesthesia delivery, which is actually very common in other nations, in other countries.
And it's a sign of the times in terms of the development of healthcare, isn't it, in the 21st century?
Absolutely. I mean, we've seen in other professions like nursing,
paramedics,
paramedics, allied health professionals, the development of their roles, and this isn't a new thing, you know. This is how healthcare is developing, and obviously, it's a changing landscape and change. There is a lot of resistance around change, but I think it's supporting individuals to understand.
That happens with change with anything, though, doesn't it? But when it's your profession, I guess it's a little bit more close to home.
Absolutely.
And so how would you describe today's and yesterday's conference? What's it about? Why is this needed now? Tell us a bit more.
So this is our annual conference. So every year we put on a conference to bring anaesthesia associates together. And obviously it's great because we can target the level of education towards anaesthesia associates, and particularly the student anaesthesia associates, which might be more workshop based and like clinical skills and hands-on, as well as lecture-based CPD and things like that. So we as an association feel it's really important to offer some very dedicated training and resources towards anaesthesia associates to support them in their professional development and support them as students as they're going through their education. But also, we are a small group. There's only about 200 of us nationally and about 100 in training currently. So we are a small group, and that's why it's more important than ever to have an annual event where hopefully we can bring people together and connect and network and express our thoughts, feelings around what we're doing, and have some camaraderie, I suppose, around the profession, which is new and growing and changing. So
brilliant. And I think we're getting a real clear sign of that today in some of the topics that are going to be following on from your talk to camera right now. And we've got some of the guests that you've invited as a committee that have been speaking over the course of yesterday and today.
And some really interesting topics, obviously some in terms of how the profession's moving forwards and updates and that, but also some really interesting topics on other things that are going to affect anaesthesia associates. So, civility and empathy is a theme that seems to be running through the conference. And again, the workshops yesterday, very technical, hands-on. And I was running one of the workshops. Great participation by all of the anaesthesia associates. Really, really pleased to hear that.
And then some of the other things, that some of the novel and the kind of what this role is facilitating. Approaches to procedures and, like you said, increasing flexibility within the workforce. So we'll be hearing all about that on the rest of this episode.
I just wanted to add on to the civility and angle that we've brought into this particular conference. We've got a lot of speakers around human factors and civility, and we've got a motivational speaker coming towards the end, and it's a difficult environment at the minute, and we want to support individuals to have an open space to reflect and be in a safe space to reflect. And I think so having these sorts of speakers allows people to think a bit more about the wider implications of how we deliver healthcare and our own impacts that we can have on that. So,
fantastic.
And we're able to now capture that. So anyone who isn't able to come, or anyone who wants to know more about Anaesthesia Associates, can then have a look at the podcast and see what it's all about.
Sarah, thank you so much for coming on and having a chat with us.
Thank you. I'm happy to be invited. Thank you.
So we're now with Nigel Roberts. Nigel, thank you for taking the time to come on the podcast to speak to us. Just a little introduction about who you are.
Yeah, so my name is Nigel Roberts. I'm an ODP by background, and I'm currently the Deputy Assistant Director of Nursing at Mid Yorkshire Teaching Trust.
Great.
Fantastic.
And on the form, you're a Mr. Nigel, but you've recently submitted or about to submit your PhD?
So hopefully my intention to submit will be in the next couple of weeks.
Excellent.
To trigger a 3-month window, then hopefully next year I'll be a doctor, Nigel Roberts.
Well, best of luck with that.
Absolutely.
So your talk today, which we managed to catch the beginning of, but we couldn't see all of, was focusing on human factors and civility in NHS operating theatres. Can you give us, for people that weren't able to make it today, can you give us a kind of an elevator pitch for your talk?
Yeah, so my talk had 3 main themes today. Never events in the operating theatres and how that links in with human factors and civility. The reason why I've done this was on the back of a 4-year PhD journey, and it became very early in the early days that the same literature from 10, 15 years ago is still prevalent and justified today. And I think the 6 golden themes that are thread all the way through the research has been talking about culture, leadership, adherence, staff attitudes. And a lot of that is very similar with how human factors, the design of the environment, whether that be the anaesthetic room, the operating theatres, how equipment is designed to help us or hinder us, whichever way it may be.
Yep.
And then civility. This is a relatively new topic, I would say. I think it's an emerging theme throughout the NHS, and a lot more research needs to be done.
You've certainly got quite buzzy, hasn't it? All this talk about
really
civility.
this conference, isn't it?
Yeah.
And for me, it's how we then elevate it to get it into the organisations, get the NHS to listen. Actually, this is a real key fundamental issue, especially when we start to look at the size of the waiting lists, the staff skills, the staff shortages. It's how we keep those people engaged and currently at work. And it's quite interesting that one of the outputs from the research has been that people want to bring it forward as a multidisciplinary team training. It's not done in silos, as in theatre staff.
So hang on a minute.
Would fit in quite
exactly,
nicely,
yeah.
right?
So there's opportunities here for simulation-based education to contribute to civility and interpersonal relationships, and one of the so this is a finding from your PhD study.
Yes, it is.
Which is showing that we need to have interprofessional simulation-based education for patient safety.
Yeah, because
How do you see that? Is that in situ simulation, do you think, in the operating theatre, for example?
So I see that because I think theatres is a high-risk environment with a codependent multidisciplinary team. And there's no point in having the training in silos, because when an event happens, the whole MDT are in there. And for me, the simulation days should be done in that theatre environment with that theatre team, whether that be an example of a patient having an arrest or a never event. It needs to be how it's dealt with. And I also feel it needs to be like a black box recording. So it's recorded, play it back so staff can see how the interactions was.
Music to my ears.
Yeah, that sounds
great. It's been a long time coming.
And that's
it really
how
has.
human factors will go in there, thinking about the SEEPs model, systems engineering, and how we can then look at each stage to go through it, whether it be the flattening of the hierarchy, the leadership, the civility, how we talk to each other. I think it all knits and integrates really well.
And have you had the opportunity to integrate any of your findings yet in your current workplace?
So yes, on 2 things. So one, I've been quite lucky that an infographic I created for the NatSIPS 8 is now used nationally across NHS England, UK, Scotland and Ireland.
Great stuff.
So I'm really pleased with that. And I think the other one is I have got a voice where I work and people are listening, and I do see a change in the tide. However, I think we're at square one as the NHS. I think we've got a long way to go.
But
interesting.
What I think I've learned over the years and gleaned from human factors, it needs to be led from the top down, doesn't it? You know, everyone needs to have an understanding about it. But if you've got that strong leadership and people who understand it and get it, that's when you're going to get the best results.
100%.
Nigel, what were the questions like at the end of the presentation? Do you have a sense that the Anaesthesia Associates here understand the importance of it?
I do. There was 4 questions at the end due to time, but I think the questions that was asked was pertinent. One of the key questions I take from today was, how do we have the hot debrief with the pressure on delivering the activity?
Right,
And I think for me, it's understanding that swarm model, getting together, and actually the trust buying into it, that the staff need time to reflect and think about the incident. And that's where quality and safety go over productivity.
So it's so interesting, isn't it? Like, again, parallels here with simulation, and effective models for debriefing in simulation may have value in those kind of hot debrief sessions. But just hearing you say it as well, for me, there's like this instant tension between hot debrief and swarm, which sound quite urgent and rapid, and then the other thing that you said was the opportunity to reflect. And it's just, again, the two are not necessarily always comfortable bedfellows, right? The urgency with which you have to operate in any clinical setting, and then the time that it takes to then adequately reflect on and unpack those experiences. So these are just new these aren't new challenges, but we face these in healthcare, don't we?
And the
real challenges.
And the debrief was the most commonly missed step from the WHO surgical safety checklist.
Unsurprising.
It's unsurprising, but it's the key step. How can we do better for our next patient? How can we do better to improve the working environment? And I think without those questions, we haven't got the knowledge, we can't learn. And we have to have somehow a way to process the information. And it takes time to do that as a team.
Fascinating.
Well, I could chew your ear off all day about human factors. We will catch up after this because I think there's some valuable stuff to talk about.
And actually, I wonder whether you might be happy to come back and talk to us again.
100%.
I think,
as doctor.
As a doctor.
Yeah. All right. That's the deal. Okay.
That's the deal.
Thank you so much for your time, Nigel.
Thank you. Brilliant. Thank you very much.
And we'll hopefully see you in the future.
Yeah. Thank you, everybody.
Cheers. Okay, so now we are joined by Carolyn Cleveland. Carolyn, thank you so much for joining us on the podcast.
Yeah, thanks very much, Carolyn.
Thank you for having me. It's a real pleasure to talk to you today.
No, it's a pleasure. So you are talking a little bit later today, but on day 2 of the conference, and you're going to be talking about a journey through civility, empathy, and emotional awareness. And you've actually got your own company, right?
Around empathy.
Yes.
So can you start off by telling us a little bit about your background and how you got into a situation where you own your own company about empathy?
I will. I certainly will. So I'm the grand age of 55 now, so I'm going to take you right back to when I was 22, so quite a few years ago. Young woman, had a very close friend who very sadly had died from a misdiagnosis of cancer and left her 4-year-old daughter, Sophie, in my care. So at a young age, when all my friends were off partying, suddenly I was very aware of that huge emotional aspect. She's starting school, but there's this big thing hanging over her. It gave me a real interest in sort of our psychology and loss and bereavement, and so I actually trained as a counsellor and specialised in loss, bereavement, and sort of vulnerability and fear and our emotional responses. If I then fast forward you then 11 years after that, Sophie's now 15 years old, and we've put lots of that sort of grief behind us and progressed with life. But she ended up being in hospital really quite poorly, but with what was supposed to have been a non-fatal illness, and she developed complications that I felt were left untreated and very sadly died herself.
Oh my goodness.
I then ended up trying to raise these concerns with the hospital, and despite having been in hospital with her 24/7 and indeed even holding her hand as we lost her, it then became very clear that to try and silence, to try and make this situation go away, even my biological status was used as a barrier. So it meant that I had to actually fight for the fabric of our relationship before I could even get somebody to look into her care. Because of my background, not only did it support my own well-being, thankfully, but it also made me question the emotional component. Was there psychological safety happening within the hospital ward when these things were happening, and voices couldn't be raised? Was there psychological safety within the complaint system? Were people leaving these systems more psychologically harmed than when they started? I certainly
also
was.
Makes me wonder how many things potentially could have got swept under the carpet if they didn't have someone like yourself with your background.
Yeah. Absolutely, and it's one of the things that I particularly if I'm doing a full day's training, I actually talk about that I'm fairly articulate, I'm a confident person, and you know, I was a very strong advocate for Sophie. But there will be some people who won't have probably that confidence. They may not have an advocate for them.
This just strikes me so strongly that we've had a couple of medical challenges recently, and if it wasn't for mine and my wife's knowledge of the healthcare system, navigating it would have been so difficult. So I completely agree. And so how does that play out into what you do then?
So because I had such a strong belief in the power of empathy and our own emotional awareness, you know, knowing what we've got going on, I talk about a model of the funnel of life and everything going in that actually, even as a very empathic person, if we've got a lot going on, we may well snap at somebody. We may well not cope with having to listen to somebody because of our own emotional reserves being low. And so I really believed in this and the reality of the situation rather than the textbook of what we should do.
Yeah, the messiness of the real world, right?
Yeah, absolutely. I mean, as a grief counsellor, I knew exactly what to do. I had 3 remaining children of 9 and 4-year-old twins, and I knew exactly what to do with bereaved children. But I was in the worst place in my life to possibly do that. So the time they needed me the most was the time I was least able to do it. And that's the messiness and the reality of the situation.
And I mean, obviously, we are really interested in simulation-based education as a methodology for training. I'm interested, and I can imagine how one might start to think about training, kind of empathy and this kind of self-awareness that you're talking about.
I'm sitting here thinking there's so many different scenarios that we could potentially run which would have such powerful learning.
And I think we should definitely get you back to talk about that in future. But tell us a bit about what you do. How do you train people to become more empathic and self-aware?
So one of my main things is actually building confidence in people. Because 98% of us are hardwired to be empathic, but we'll all have different biological starting points. But I really wanted people to believe in their abilities. And so the reason I tell my story, which I tend to do fairly upfront, but in a light-hearted way as possible, because I think when we're feeling at ease, we're much more likely to take on difficult information rather than I can't hear this and put the defence barriers up. But I do that because it evokes their empathy, it evokes their compassion. And so right at the beginning of a training day or even conference session, they're feeling it. And I then actually draw attention to this. Actually, you've all just sat there and had cortisol released and oxytocin released, and you're not aware of it, you don't know it's happening, but it is. And so it reignites actually their own belief in themselves. And we go into the sort of meaty science of it, the neuroscience of it, what's going on in our brain, the different kinds of empathy, of cognitive and affective empathy. But I really take them down into quite a deep level.
I mean, it sounds phenomenal. I mean, looking forward to seeing you talk a bit later, but you basically provide your students or your audience in this case with a concrete experience of their own empathy and then use that as a vehicle to then unpack the things that might contribute to it or to build it. So in many ways you sort of run a simulation in its own, except it's not a simulation because they are genuinely feeling that empathetic tendency towards you in that moment, and you can then harness that.
What we often do in the debrief component of the simulation, isn't it, is get learners to tap into their previous experiences.
Yes.
Yeah.
And that's what you're doing with storytelling, essentially, isn't it?
It is. It's exactly what I'm doing,
So what is your talk about today with the Anaesthesia Associates in particular?
So it's really just opening the door. However, it will have my story within it. So it still evokes those kind of reactions that I would get if I was spending the whole day or 2 days with them. And then it's a bit more of a whistle-stop tour just about some of the statistics around it, looking at the empathy model and actually focusing in on how much we catch emotions. And so they will be catching some of my emotions. There will be parts in times in the room where it will more than likely go to pin drop silence because people will be feeling that emotion. It will feel tangible, and we will then have humour and fun and a couple of funny videos because we need that. But it just shows how much we respond to each other and we catch emotions, we catch attitudes, we catch ideas from each other. But it will also have a strong level of well-being and how are you today?
All of those emotions are definitely very much part of the environment that you work in an operating theatre. You definitely need a certain amount of humour. There are definitely moments where, like you say, everything stops and there's a pin drop silence. And understanding and learning how to deal with those emotions is really challenging sometimes.
Sounds like it's going to be absolutely brilliant.
I hope so.
Best of luck for your talk.
Thank you.
And thank you so much for joining us to talk about it.
Thank you. It's been an absolute pleasure. Thanks very much.
Okay, I'm now joined by a very excitable Dom Lewis and Paul Cutts, two Anaesthesia Associates based at the Norwich University Hospital. Paul and Dom, welcome to the podcast.
Hello.
Thank you.
So we thought you'd get you on because firstly you're Anaesthesia Associates and we're at the annual conference, but also you've done a little bit of the organising behind the scenes because we're based in Norwich, and basically the annual conference goes around the country, and wherever it's local you get lumped with sorting the finer details out. Is that how it works?
Essentially, yeah. There was 3 places who volunteered for this year, and I wasn't quick enough to pull out when the other 2 did.
Is it like when you ask for a volunteer and everyone else steps back?
I was the last man standing, so to say.
They've been leaning on Norwich for about 2 or 3 years, and we ducked it 2 or 3 times, and landed with this one.
So we've had to basically choose venues, get sponsors, sort out speakers, like yourself, Tony, having a great workshop, which was really quite informative.
Oh, thank you. You're too kind.
Got to say that on your podcast.
So we're at the Assembly House in Norwich, great venue.
It is.
Yeah,
really
lovely.
nice, isn't it? And just give her a flavour of what's been happening over the past 2 days.
So we've panicked getting equipment. So in hindsight, probably looking at getting equipment slightly earlier. But it's essentially the setup for yesterday was getting all of the equipment that we could possibly get, so that they got maximum exposure to the appropriate workstations that
I've
we
never
had.
seen so many ultrasound machines in one place at any one time.
That was wonderful. So
That
we had
took a lot of emails.
Yeah, I bet it did.
And actually, getting the tables was harder than the ultrasounds. So I didn't really want people lying on kitchen tables to be having their legs
get
scanned.
proper couches and stuff. And we had some ODP students, didn't we?
Yeah, they
who
were
were your
fabulous.
ultrasound models yesterday.
Yeah.
Terrific. Yeah. So we had Amy, Genevieve, Laura and Sam. And they did an amazing job. They really enjoyed being part of the demonstrations. And of course, when you're having yourself scanned and it's being pointed out to the students, you get to learn too. So
I think they got a lot out of it. They got an appreciation of things that they wouldn't normally see. So I think it benefited from that point.
Great stuff.
And it's also worth mentioning, I think, 75% of Anaesthesia Associates are former healthcare professionals of other guises, ODPs or nurses, etc. So it's good to have them involved in the AA world right from the start. That's really cool.
Brilliant. And I've seen a couple of my alumni who've gone on to be Anaesthesia Associates here over the past couple of days, so it's great to see those people as well. So think about it from a simulation point of view. Where would you like to see Anaesthesia Associates moving forward in terms of simulation, education and training? Because Dom, we've done some work together.
We have done some work together, and we've got more coming up later this month,
we have indeed.
Which is going to be terrific. Simulation forms part of the Anaesthesia Associate curriculum, so it is mandated that we have to do OSCE practice, and then we have an OSCE exam. We did ours at the 24-month point, and in the new curriculum, that's been brought forward even more. So you do simulation in part-task training, you do simulation in the lo-fi ALS model, and you do simulation in the high-fidelity model, which is hopefully what we will develop. And I would like to see that grow not just with us into a regular thing, but grow around the country as well. So Anaesthesia Associates and student Anaesthesia Associates training alongside student ODPs, and then it almost becomes seamless in the workplace where you have your supervised student AA working with their supervised ODP student, and working with their supervised ODP student.
Sorry about that.
And
the joys of organising a conference.
So are you on in a couple of minutes? Are you?
And hopefully that then builds into a culture of continuing simulator training as qualified ODPs and qualified AAs, and then hopefully that bleeds off to our medical colleagues too. Because although anaesthetists in training get sim training,
a lot of our consultant colleagues don't get a lot of access to
there's
SIM.
a real desire, isn't there, for multidisciplinary, interdisciplinary simulation training. That then becoming a reality sometimes can be challenging. So any models that we can use where it's been successful, I think, is definitely a step in the right direction. Paul, you're going to say something.
I think you can look at the ALS sort of training where you do have multi-professional interaction in the delivery of teaching. Certainly when I do the ALS course, and I think you do as well, Dom, we don't introduce ourselves as nurses. I am a qualified nurse, but I'm also an AA, so I actually introduce myself as an anaesthetic associate. And it's just putting the name out there and highlighting the fact that actually we're happy to teach or to do stimulation with anyone who's prepared to be engaged and motivated to do that sort of thing. I think simulation's really important.
Yeah, great. Well, you're both very busy because you've been doing a lot of organising. I think you've got places to be, so thank you both very much for coming onto the podcast.
Thank you, guys. Thank you, Tony, for supporting yesterday with the workshop.
My pleasure.
Wonderful and good feedback from that. And thank you for coming along, because it has been great to have you here supporting our event.
Yeah, we're more than happy.
Yeah.
Thank you.
Come again.
Cheers. Thanks very much.
Do you want to do Birmingham?
Road trip to Birmingham?
On it.
Yeah, we'll do it.
Nice one.
Cool. I'll let you Birmingham guys know.
So we're joined now by Simon Harmer. Simon, thank you for taking a couple of minutes to come and speak to us on the podcast.
Thank you for having me.
And you're going to be closing out the show today, aren't you, with your keynote presentation?
I am, yeah.
So what are you here to talk about?
So I suppose loosely, it's. I suppose I'm talking about me. However, I'm lots of different people. Lots of people that have been wounded, injured, and sick on operational tours. So I was a member of the UK Armed Forces. And I'm a lot of people's different stories in different contexts, really. So I suppose I'm talking a little bit about what happened to me, but with a little bit of a difference, that because I was a medic, so I'm just looking at it from both sides of the stretcher. And then I suppose also a little bit of resilience as well, because resilience and being resilient is very important to me. But what does that actually mean? What is resilience, and how do you become resilient?
Okay, so you were wounded whilst you were a medic in the army, was it?
Yes, I served as a medic in a Royal Army Medical Corps, and of course, medics are needed on the ground, and on a foot patrol. I activated an improvised explosive device which took off my right leg and damaged my left leg irretrievably. So I'm a double amputee, injured my arm, and had a few other injuries as well.
Okay. But so fascinating to hear it from both sides of like you say, both sides of the stretcher.
Yeah, and interesting, 2 days before I was injured, I was treating 3 gunshot wounds. So, the difference that I saw, and actually what I learned from being injured and not being able to use that knowledge, to treating, all sorts of different injuries, whether it was IED blasts or gunshot wounds, and how how that was managed, really.
Yeah, interesting.
Yeah, really interesting. And in a conference that seems to have quite a strong theme about
civility and
focusing
empathy.
on civility and empathy. I just think that's really interesting that you are able to present both of those perspectives, both as clinician and as you were saying just before we started, casualty and patient, and how those are two different things. And so settling somewhere in the middle there and giving that perspective, I think, is really valuable. What do you think it gives people?
Well, so one thing I did find along my sort of patient journey is the communities that I've generated along the way and become part of. And actually one of those key communities is the people that treated me. Right from the point of wounding all the way through the different hospitals I've been to. So, obviously I was treated out in the hospital in Camp Bastion.
Okay.
I went to Selly Oak in Birmingham, QE in Birmingham. I went to Queen Victoria in East Grinstead. I've been to Frimley Park down in Aldershot, and I've spent a lot of time at Salisbury District. So I've done the rounds, and I've experienced every facet of the NHS that you can really have. And I've had a lot of surgery along the way.
Sure. And I think what, you being here and being able to present that in the way that you do, I think it just illustrates, doesn't it, to everyone in a conversation about professionalism and professional identity, that actually all of this is about the people that ultimately are receiving that care, who feel part of that process. As you say, like you described kind of becoming almost like forming not a team, or forming a connection with the people that you're being treated by.
That's extremely powerful, I think, isn't it?
And you mentioned that about resilience as well. So talk to us about that.
Yeah. So resilience. There's lots of buzzwords that are thrown around, aren't there? And you need to be more resilient. Well, how do you become? It's like, how do you become more resilient?
Yeah.
What is resilience? Well, for me, I kind of I discovered what it is, and that I was already doing something to create a resilient sort of mindset by the things I did before I got injured. And I think throughout life we can prepare ourselves for those things by doing things that stretch us a little, and finding the limitations of our own physicality, or our own physical limitations or mental limitations, whatever it is we want to do. And it's just about finding and enjoying experiences all over, from traveling, from meeting new people. And it doesn't have to be going to Bali or Thailand.
No.
It could be, getting outside just in the fresh air, and just raising your heart rate a little bit, joining a group, just finding your little niches in life. And the more you sort of try different things and do different things and stretch yourself a little bit, because I think there needs to be a little bit of stretch there, you'll find that you become more resilient, and you are developing resilience. So it's something that needs to be built on and worked upon. Just like a muscle, you need to
train it.
You need to train it,
yeah.
And you need to actively go and develop it. And you might go along and do something. Say, for example, it's abseiling. You might go and try it, and you might do it. And you might think, yeah, that was brilliant, but I never want to do it again. Because there's types of fun, isn't there? Type 1 fun, 2 fun, and 3 fun. Type 1 fun is fun. It was fun to throw out the whole event, and it was really enjoyable. Type 2 fun was enjoyable after the event. And type 3 fun, and there was nothing enjoyable about it at all. So, I think that the first 2 funs are probably quite the ones we want to aim for.
Yeah.
But actually, I think where the magic happens is actually at type 2 fun, where you do that triathlon or whatever it is you wanted to experience, and you go, yeah, that was an absolute mission. It was hard work, but afterwards I can look back and it was fun doing that.
And that sense of achievement as well. Great. Fantastic. Well,
thank you so much.
Thank you very much for coming on the podcast, and we hope the presentation goes well.
Cheers. Thanks very much. Cheers.
Thank you.
Right, okay, so that wraps up the keynote presenters for day 2. We weren't able to catch everyone just because of the logistics and it being quite a busy day, but I think we got a really good... We captured the essence of the day and kind of some of the...
And like any good conference, it's been great to make some connections and to meet some new people, and to think and to share ideas. And as Carolyn said, like feelings, emotions are like catching, and so are ideas. And I think we've found some really interesting parallels to talk about simulation-based education today.
And as any good kind of entrepreneur does, we've potentially lined up some future episodes.
Yes,
we definitely need to get a couple of people back. So we weren't able, like we said, to capture
Dr. John Paul Jeans and talk about the role of AI.
But we're definitely going to get him into the studio, and we'll unpeel back the role of AI in healthcare education, medical education in the future.
What was the most conversation that struck you the most?
I mean, listening to Simon talk about his story, fascinating.
Yeah.
But I think, and we've hinted on this already throughout the episode, this recurring theme of empathy and civility, and kind of the hidden areas, if you like, of everyday practice that we probably need to be a little bit more aware about. I think that really resonated with me.
I concur. I think what's been what's been really profound for me has been this real human strand that's run through something to run through this conference, and that's been really nice to hear about. Whether it was, Carolyn's also, her own history and but also the importance of that. But yeah, like you say, Simon's talk as well was really powerful.
And for me, it's that empathy and civility. Firstly, for your patients, obviously, it goes without saying. But like Sarah was talking about, it's a profession in its infancy, and it's growing, it's developing, and evolving in a changing time. It's an empathy and civility for the profession as well, and the individuals involved in it. And I think in a time where healthcare has got its back against the wall in many instances, I think that's a really important message to take home.
Absolutely, yeah. Something that we could all learn from the way that this Anaesthesia Associate Conference has been conducted, and its central message about humility, compassion, and civility, exactly as you say.
So this has been a slightly different episode, isn't it, than the normal SimCast. We hope you've enjoyed it, and I think we'd like to explore other opportunities where we can go and be at conferences and kind of get this almost journalistic approach to what's happening.
It has felt a bit different, and if you have enjoyed it, do let us know in the comments why. It would be really good to know. If you didn't, equally, do let us know, because we're always keen to improve, as Tony says at the beginning of every episode. Normally,
that's my tagline. But one of the things, actually, just before we end, one of the things we've talked about here is you often go to a conference and they're all relatively decent, aren't they, in terms of the content? A lot of planning goes into these things.
A lot of effort.
And you come away and you think, that was a good conference, but then it's kind of lost in the sands of time, isn't it?
Yeah, it's transient. Yeah.
And which is one of the things why we're really keen to be able to come to conferences like this.
Delighted to be invited to be here to do this.
And then, firstly, it gives people who didn't have the opportunity to come a flavour of what it's like. Obviously, not the details as such, but also it's an opportunity to network and to get that message out there to a wider audience.
Yeah. So we hope you've enjoyed this slightly different version of SimCast. We'll be back in the studio, I think, probably next week.
Yes, so the next episode's going to be a good one.
Yeah.
Ties in with Halloween.
Oh, exciting. Thanks very much for listening. Take care, and we'll see you on the next one.
Thanks very much. Bye-bye.